Good evening, everyone. Welcome to today's Ophthall Surgical Video Club. This is the Telegram group that we have created in case anyone wishes to join so that we can have active discussions on the group. You can please join through the QR code. Myself, I'm Dr. Mukul. I practice in my own hospital in Manjushri Hospital in KGF. And I take great pleasure in inviting my friend, my senior from my alumnus Tirunelveli Arvind. He's a Dr. Sailesh Dabke. He's done his cataract and glaucoma surgeon and is MD of Dr. Dabke's Infinity Vision Eye Care Hospital, Bidar, Karnataka. He finished his glaucoma fellowship at Arvind Eye Hospital, Tirunelveli. He's done publications in many peer-reviewed journals and faculty in major ophthalmological conferences, and also shares his surgical education through his YouTube channel. Welcome to the Surgical Club, sir. I'll stop my screen sharing and you can take it from here. Since we have a lesser audience today, let it be a more interactive session. The participants can stop this thing at any point of time. If you have any doubts, please feel free to stop and ask your queries. We'll be more than happy to answer. So I'll stop sharing, sir, now. Yeah, and now you can share, Dr. Sailesh.
So my screen is on, right? The title page, and it is.
Yes, sir, we can see it.
All right. So since it's a small group, it's good in a way that we can discuss then and there. Before I begin with today's discussion, I would like to mention certain things. It's just that I'm going to show a series of videos of different nucleus disassembly techniques, probably 7 to 8 techniques of them. Most of them are mine, except for the MyLoop clip and the few couple of videos by Dr. Lahane in the end. And also, I would like to disclose, like I am a big fan of Dr. Nito. So most of these clips you're going to see now is going to get you a sense as if you are going to watch, you are watching Dr. Nito's video, but that's not the case. It is going to be my video. And also, since it's going to be a series of clips wherein we are going to talk mainly about nucleus disassembly techniques, I would want to have discussion on that particular technique at the end of it, since we are going to have a plethora of different disassembly techniques wherein we are using different instruments or different discussing them then and there would be better. So on that note, let's begin. So first technique of nucleus disassembly would be one which we all begin our phaco journey with, the classical stop and chop, wherein a trench is initiated from the subincisional area going all the way across to the opposite equator. A trick at this point would be to have the appropriate phaco tip exposure so as to keep the phaco tip long enough so as to have a good access to the deeper regions of the nucleus. And the width of the trench ideally has to be 1.5 to 2 size the width of the phaco tip so that there is enough space for you to move around with the phaco probe. You trench all the way across from one equator to the opposite equator. Then you rotate the nucleus by another 90 degree. A third trench is then initiated. At this point, as you trench begins from the center going towards the periphery, one has to be wary about not going too deep as you reach the peripheral part of the nucleus. So in this manner, once the 80 to 90% depth of the trench of the nucleus is reached, the two instruments are then placed deep in the bottom of the trench and we then just laterally separate. This is followed by individual quadrants being rotated by 90 degree and emulsified. The next technique would be the stop and chop, wherein a central trench similar to what we saw in the previous technique is seen. Once the 90% of the depth is reached, at this point a tip would be to have a phaco parameter set in appropriate so that the power is not too much, which becomes riskier once you reach the deeper planes of the nucleus, nor the power is too less, which causes, rather than eating up of the nucleus, you tend to start mechanically pushing on the nucleus, which you don't want to happen, so that the phaco parameter or the phaco power has to be hit that soft spot. So once the appropriate depth trench is made, the two instruments are then used to laterally separate and we get a two heminuclei. These two heminuclei are then subsequently chopped or eaten up directly depending upon the grade of cataract. which can then be easily emulsified. The next technique would be a technique.
Sir, let me stop you there. Two videos we
Yes,
have seen now.
yes, yes.
It would be helpful if you could share what phaco machine you are using and the parameters that you use for each one. Can
Yeah.
you please
So
tell?
yes. So in the clips we show right now, the clips, most of them, there are going to be multiple machines. One would be your first one would be J&J Compact Intuitive. The other one will be our Legion, and the third one would be our Constellation, wherein I use only the FACO part of the Constellation machine. So this would be the machines which I'll be using, and it's a 2.4 incision in most of the cases, and rest of the cases it is 2.8 with a bent Kelman tip, FACO tip. Apart from that, setting depends upon the individual case and what technique I am employing. So probably it would be best we could discuss it based on a individual need basis. And obviously, for the two techniques which I had shown, the trench part, the parameters has to be on a lower end, probably a vacuum of 80 or 100, and aspiration rate of as low as 12, 14, 18 should be good enough. And I already mentioned about the appropriate power parameters which needs to be set in. So anything apart from this, if there is any discussion on to the divide and conquer and the stop and chop we discussed about, please let us know.
And regarding the bottle height, and I think these systems have active fluidics also, no, sir.
Yeah.
So, what would you suggest to keep the bottle height in case of a beginner who's trying to learn from go from divide and conquer to stop and chop? So, any
Yeah.
suggestions regarding the bottle height?
A moderate bottle height wherein 60 to 70 should be decent enough to begin with. See, bottle height is something, it's always better to begin on a moderate level and then gauge based on your surgical technique. So it's hard to dictate this would be the bottle height. So it's always better to begin with a moderate bottle height somewhere in the range of 60 or 70, and then titrate depending on your own speed and the machine you are using.
Any questions from our audience? If they want to ask anything, you can ask now, or you can type it in the chat, and I can ask Dr. Sailesh. So, yeah, we have a question from Dr. Arun. He's asking regarding the size of the chopper. Can you please go back to the previous videos, sir?
Yeah.
I thought I'll introduce your chopper in that video.
Yes,
I
yes. No,
don't know
I'll be
whether.
talking about that. I'll be talking about that. Yeah. So if you could see here, it's a ball chopper. It's basically sized as per Dr. Nito's dimensions. What this chopper has is that it has got a 0.25 ball at the terminal end, followed by 1.25 or 1.5 length of this bent. So this is the ball chopper, what I am using. And at this point, if you could see this ball chopper, I am engaging just
Let me
underneath.
stop 1 second, sir. Dr. Naveen, can you please mute yourself? Dr. Naveen Kumar.
Yeah.
Yes, please mute. Yeah, continue.
Yes, so the second instrument is a ball chopper, and is this is by Dr. Nitos. The dimensions are as per Dr. Nitos chopper. Probably for Indian eyes, such a long bent 1.25 or 1.5 will be too long, and the ball size will be too thicker. What I prefer right now, I have got my own chopper wherein the ball size has been decreased and the bent length is reduced to 1 So which would be ideal, which is available with cardio care. So basically, it's a ball chopper. If that's fine, Arun, it's fine. You got it cleared?
Yes, thank you.
Yes, yes.
Yeah, hello, sir.
Yeah, hi.
My name is Srijan. I have a doubt.
Yeah,
While doing phacoemulsification, actually there'll be various kinds of illumination in the microscope.
right.
Like one is retroglow, one is red glow, one is retroglow with red glow, one is just plain light without the retro and red. So please can you tell me, sir, which light to use for which step of the phacoemulsification? From
Yes.
the
So normally for a microscope wherein both the coaxial as well as the retroillumination is there, ideal would be in the stage of rhexis That is when the retro mainly comes in. If a good microscope with a very good retro illumination, you need not even have to use a trypan blue. The retro will be so good. So definitely, I would want to do a Rexis stage. And once you have hydrated, hydro dissection, hydro delineation is done, you tend to lose that glow you were getting earlier. So at that point, you can shift back to your both the illuminations. And once you have eaten off the pieces and then you're back to the cortex aspiration, you can come back to your retro again. So plane where your visual axis is clearer, coaxial would be good. Things would be easier. And once the cortex aspiration is done, IOL implantation followed by visco removal can also be done in retroillumination on. Even with a good retroillumination, you can even see individual strands of visco that is left behind. So that would be the thing about the illumination.
Thank you, sir.
Yeah.
If there are no further queries, we'll proceed to the next video. Sir, you can continue.
So we just concluded with the stop and chop, concluded with the 4-quadrant followed by stop and chop. Next would be a technique, probably a phacosurgeon who has just begun, well versed with the two techniques which we saw. He would want to transition into a more advanced form of a phaco chop techniques. The first would be the vertical chop. In the vertical chop, what we do is the subincisional nucleus is engaged with the phaco probe in this manner. Ideally, the point of engagement onto the nucleus would be a transition zone where a central dense nucleus and a relatively softer epinucleus or a cortex. That transition zone, you need to impale the nucleus with the phaco probe. Once sufficient impalement is done subincisionally, what you do is you keep engaging onto the nucleus while you are going more deeper, more posterior. Once the appropriate depth is reached and sufficient purchase on the hold of the nucleus is got, the second instrument is positioned in this manner. At this point, the trick would be the phaco probe has to be lifted vertically while the second instrument presses on vertically posteriorly. Hence the name vertical chop, and we get a good lateral suppression or a crack. So anything until this point, anything about the vertical chop, any queries, any discussion anyone would want to have? Transitioning about or vertical chop per se?
Regarding the chopper, if you could mention few points, sir. Because
Personally, for a chopper, I am not a surgeon who would want to have a sharper instruments in the eye. So no matter what the grade of the cataract, I am going to use either a ball chopper or a long Sinsky. These are going to be my choppers. It's purely subjective. There is no one way about it. When it comes to preference of the chopper, it's purely individual surgeon based. So that's about the second instrument I would like to comment upon.
because the ball chopper, the one problem is if you try to do vertical in that, you end up pushing the nucleus down.
It's not possible. It's not.
Yes, it's not possible.
Yeah. Horizontal chop introduced by Niagara way back. It was purely for with the use of ball chopper, and the physics and the mechanics are such that it is practically not possible to do a vertical chop with when you are having a ball instrument in hand. So obviously, it's for the horizontal chop. Yes.
Yes,
We'll
sir. Any questions regarding that from the audience? I think in the chat also there's no questions, sir. You can proceed.
Yeah, so once you got a decent enough exposure on to doing the vertical chop, next would be a horizontal chop. So one thing about horizontal chop is that I call horizontal chop technique and a horizontal chopper the unsung hero, because not many surgeons are prefer doing this horizontal chop, and I'll be talking about why that is the case, and it is really doable once you understand the physics and mechanics of it. So let me get you introduced to the horizontal chop. So in the horizontal chop, the same nucleus engagement as discussed earlier with the vertical chop is done. Subincisional nucleus is held on with a good vacuum, with a good grip on with the phaco probe. Once the sufficient depth has been engaged and ensuring a proper hold on to the nucleus, the second instrument, the ball chopper, it goes underneath the rhexis margin, hooks across the opposite equator. Once this is done, at this stage, the second instrument from the opposite pole and the phacoprobe onto the substance of the nucleus keeps moving towards each other, and we get a lateral separation. So once the ball chopper goes across the opposite equator underneath the rhexis margin, it sort of becomes sort of a blind maneuver. So only thing that comes to your rescue at this point is your orientation of the structures, how at the equator or beyond the equator your instruments are. So you need to have a good anatomical orientation of the structures in the eye, and to what extent you are going posterior, you need to be aware of it. Yes, it tends to become a little bit of a blind procedure momentarily when you are there, but with good orientation of the where the structures are and how they are located, it is pretty doable. So one variant of a horizontal chop, wherein initially you need not have to even engage the nucleus. So without any use of an ounce of a vacuum or a phaco power, you can actually disassemble. You can actually make multiple pieces, and that variation of a horizontal chop is known as wedge mechanical separation. So here's an example of it. What I have done right now is the second instrument with slight supination movement. The ball chopper is made to traverse underneath the rhexis margin. Once it has reached the opposite equator, it hooks across it, getting a good hold at that position. Now the second instrument, the phaco probe itself acting as a other instrument, just mechanically engages onto the surface, and the two instruments are traversed towards each other and pieces get separated mechanically. So you are not even using an ounce of a vacuum to hold on to the nucleus or a phaco power to engage onto the nucleus. So you're just mechanically using the two instruments to achieve a wedge mechanical separation. As you can see here, the second instrument goes across underneath the rhexis margin, hooks the equator. The phaco probe, you can see it is not using any power, it is just mechanically impaling or holding on to the nucleus, while you can see the second instrument traversing across the substance of the nucleus, and they are laterally separated. So this would be the wedge mechanical separation. This becomes very, very, your rescue technique when you are stuck with a soft nucleus, which is neither easier to chop nor you can eat it in toto, especially in case of a diabetic cheesy cataracts. It becomes real challenge because you can neither easily chop them nor it is easier to hold on to them. So this wedge separation becomes a very, very good technique to come to your rescue in such a situation. These horizontal chops, wedge separation are something which not many people do it, but I'm a big fan propagator of these techniques. So any questions, any queries with respect to this would be I would love to answer at this point.
Yeah, sir. Regarding your horizontal chop, any cataracts you would prefer to do, and any cataracts where you don't want to do horizontal chop, sir? Is there any criteria?
Yeah. So for me, a ball chopper is something I use in all grade of cataracts. You will be seeing the subsequent videos. Like right now, I showed you relatively cheesy, softer cataracts to moderate grade cataracts. Now we'll be transitioning, wherein I'll be using a ball chopper in a relatively harder NS3, 4 grades of cataract as well. So when it comes to ball chopper, there is no cataract preference as such. It is pretty usable across all the grades of cataract.
Like let's say in a case with pseudo exfoliation, sir, and in a case where you have the bag instability where you need to use a CTR and a CTS segment, would you like to proceed with this horizontal chop if there's a hard cataract?
Yes, I would want to go ahead because when it comes to chopping a harder grade of cataracts or a compromised back complex cataract, you want minimal mechanical stress on the things. So what we are doing here with the ball chopper is that we are engaging the nucleus with the phaco probe when the nucleus is sitting in the substance of the bag, and the second instrument which is going across, it is confined to the space of the bag. So whatever you are doing, even the chop, the crack that is happening, you are exerting, you can exert as minimal lateral separation as possible, because you are going, because both the instruments are going in line in the same line. If properly done, yes, I'm not justifying this is the technique for such a situation, provided you know the physics of it, you know the mechanical aspects of doing this particular technique. Definitely it is not going to exert any additional zonular compromise in a pre-existing zonular compromised eye. And CTR, CTS, yes. I mean, you are using ball chopper in a stage wherein probably CTS hasn't gone yet. So I doubt it is going to hinder usage of ball chopper in the presence of a CTR anyhow. Yes, in presence of implantation of CTR, probably you can do it, provided you are aware or you have a good microscope which enables you to proper visualize whether you have actually engaged the CTR or no. So all those factors does matter.
And I've noticed that you're using Kelman tip for your mechanical wet separation, sir. Have you
Yes.
tried doing it the straight tip like?
No, I haven't tried. Mechanically speaking, it is easier because the bend tip provides you that sort of engaging edge to impale on the nucleus with a straight, not a Kelman tape or not an angled one. Probably it will be a little difficult, provided the whole surface, whole circumference of the phaco tip is properly engaged. At that point, probably you can try doing it. But personally, I haven't tried it with a tip which has that sort of a tip.
I think it's the same question asked by Dr. Arun. What angle of phaco probe, 30 or 45 degree for wedge chop? I think he's asking regarding the tips, the 30
I know,
degree
I
or
know.
45 degree.
Got it, got it, got it. So definitely, there is no particular thing about the angle. As long as there is angle, it is easier, irrespective of 30 or 45, because that angle of the phaco tip provides you that sort of a partial cutting thing or partial edge through which the nucleus can sort of be impaled upon. So any angle is fine. Any angle is fine. In fact, even if it is a non-angled one, you can, provided the phaco tip is has got enough purchase against the nucleus, which mechanically holds on to it. So that much is good enough.
Any other questions from our participants? You can proceed, sir, the next one.
Yeah. So as we discussed, we are transitioning from a softer to a harder grade of cataract when it comes to horizontal chop. In such a situation, it is wedge mechanical separation, a variant of horizontal is practically not possible. In such a situation, what I would do is a modified horizontal chop. This technique introduced by our dear Dr. Pradeep Mohanta sir, what is known as the submarine chop. In this, what we do is everything until this point is the same. You impale onto the substance of the nucleus, deepest part of the nucleus possible with a good vacuum. Once you have a good grip onto the nucleus, you go underneath the rhexis margin, hook across the opposite equator. At this point, when it comes to a submarine technique, what you are doing is the second instrument, where it is staying, it will stay put. It will be stable there. Now, the phaco probe will traverse through the substance of the nucleus like a submarine, going towards the second instrument, and you get a crack. So if you could see, the substance of the nucleus is engaged. Once you get a good grip, the second instrument goes across the opposite equator. The second instrument stays there. At this point, it is the phaco probe that is traveling through the substance of the nucleus like a submarine. And once appropriateness between the two instruments are reached, they are laterally separated. So this is a variant of a horizontal chop known as submarine chop. It does help in a really harder grade of cataracts, NS3, 4 plus grade of cataracts, wherein it is real challenge to sort of reach the posterior plate and to get that through and through total posterior plate separation. This technique is something you can definitely come to your rescue. So if
You can proceed, sir. We'll go to the next video.
yes.
Dr. Srijan, yeah, please.
Sir, while doing submarine chop, in which foot pedal we should be in, whether we should be in phaco, foot pedal 2 or foot pedal 1?
It will be 3. It will be 3. Because you want,
Yeah.
yes, you want, what the phaco probe will be doing at that point is it has to traverse through the substance of the nucleus with a panel based, usual panel based vacuum setting, what it is there in the phaco 2 mode, traversing through would be a little difficult. And also in the phaco 3 or the setting wherein you want little good enough aspiration to be happening, at the same time you want a control over the vacuum as well. So what setting we place for when we are eating up the pieces or during phaco 3, that would be an ideal setting.
Okay.
Yes, that would be an ideal setting.
Thank you.
Yes, and other thing when it comes to submarine chop would be to have a good enough phaco tip exposure. You want your sleeve to be positioned, you want phaco tip to be longer enough so that it doesn't come obstruct when there is traversing of the phaco tip through the substance of the nucleus. So one thing would be to have a longer phaco tip exposure.
How much exposure would be ideal, sir, for submarine chop? 2
There's
mm,
nothing.
0.5 mm, or 1 mm?
I would, there is no hard to say like that, but anything depending on the grade of cataract, what decent enough, longer enough exposure is good enough. There is no 0.75 or 1 mm like that. It also depends upon the phaco tip and the different phaco tips available with the machines as well. But whatever length feels longer than your routine cases should be good enough.
Oh, thanks.
It allows engaging, yeah. Yes.
No other questions, sir. We'll go for the next video.
Yep. So next would be another variation of a horizontal chop, wherein known as the double chop or a cross chop. The first chop is by wedge mechanical separation, as we have discussed earlier. Once this is done, the second chop would be what is known as a transverse chop. We are not going to rotate the nucleus any further. We are just going to keep things as they are once the initial chop is achieved. The ball chopper then goes across in this manner transversely to the other heminucleus, and we have a small piece available. Once it is eaten up, we can just go ahead and emulsify that. So this would be a variation of horizontal chop, wherein known as a double chop or a cross chop. This is mainly for the harder grade of cataracts, which tends to become little trickier if you are not able to get a good central crack, or if you are ending up with you may end up with a ball which is hard to get onto. This would be a softer grade of cataract. This would be a decent technique so that you have eaten up one piece already, and there is less possibility of being left behind with a ball. Yes.
Sir, horizontal chops, I think we have shown it so beautifully, make it look so easy.
Yeah.
Please tell us about the learning curve also, sir. How difficult what is and what complications you faced in the beginning. Like when you were
Yes.
trying to do horizontal chop, was there any particular thing which you would have to take notice?
Yeah. So when it comes to horizontal chop, transitioning from the stop and chop, divide and conquer to vertical chop, the way it happens, probably same sort of transition happens from vertical if you're trying on to the horizontal chop. That is one part. Yes, definitely learning curve will be there. But only thing is, if you are good with your vertical chops, if you are good with where you are impaling, how much you are impaled on the substance of the nucleus, how good is your grip on the nucleus, that you will get once you are well versed with the vertical chop. So once that is done, once you are sure you are not going to lose your grip on the substance of the nucleus with the parameter setting or with your surgical expertise, once you have got a hold of yes, my nucleus is impaled on the new substance of the nucleus and I am not at an appropriate depth. Once you got that much of a orientation of your phaco technique, probably that would be the right time to transition. Other thing I would suggest is having a, I mean, with the compromised microscopes with not so good retro illumination, it may become a little trickier because you would want a good visualization of the anterior capsule, where your anterior capsule is. If not visualization, you should be having a number of surgeries in your bucket enough to have the orientation where is your excess margin. So if those things you are conscious of and aware of, definitely you can go ahead. So a good microscope and a good orientation of where the anterior excess margin is, where your tentative equator nucleus equator is, these are the things you need to well versed, and that comes probably once you are well versed with the other vertical chop techniques. Once you are there, transitioning becomes easier because you need to have that orientation of the anatomical structures. Yes, learning curve will be there. The ball size, the length of the bent, what needs to be there. It is purely surgeon based. Start with softer cataracts. Then probably you can gradually transition to the harder grade of cataracts, because going across the opposite equator becomes a little challenging in case of a harder grade of a cataracts.
And any initial complications you faced, sir, when starting this horizontal chop? Was there any zonular dialysis, peripheral PCRs, or something like that?
Thankfully, I had Lumira I with me when I was working at an institute elsewhere. So thankfully that never happened. But yes, definite probabilities are there if you're under the assumption that you are under the rhexis margin, but you are actually anterior to it, you are going on to the capsular bag around the zones. Yes, probability is always there, but it's always good practice to once you go across and you have engaged just to nudge your second instrument, just to see, you'll get a feel of the intercapsule probably getting elevated or nucleus freely moving across. So that will give you an idea whether you are actually within the bag complex itself. So once you are across the opposite equator, keep it there, just nudge it a little to the left and right, you'll get an idea. Intercapsule, probably you'll be able to visualize intercapsule getting tinted up or the nucleus moving freely within the back complex. So that will give you an idea you are actually within the back complex.
Thank you, sir. Any questions from our participants regarding horizontal chop? Okay, Dr. Arun is asking, did this ball tip chopper create PCR? He wants to know whether a PCR has occurred with this
No,
ball tip
no,
chopper.
never, because it is such a smooth surfaced one. It itself touching on to the PC will not cause PCR. In fact, there are times I tend to use certain cortex bits which is off from the anterior within the anterior capsule confines. A small bit sitting on the get stuck on the PC certain times. You have eaten up rest all the things, but cortex. A piece of it, a chunk of it, literally is stuck on the nucleus. You can actually go in with your ball chopper and mechanically sort of swipe it across. So I also, when I am eating up of the cortex, certain times, if at all a bare bag, in case of a hypermature cataract, you can use this ball chopper to sort of place across the posterior capsule, which prevents the PC from getting tented up and aspirated. You can actually place this ball chopper across the PC when you are eating up of the last pieces in a bare bag. You can sort of keep this ball chopper as a guard as well. So it's itself causing PCR, it's not going to happen because it's of the smooth surface of the ball.
Okay, no other questions, sir. You can proceed with the next video.
Yes, so if at all still people are not convinced with the horizontal chop and want to go ahead with the vertical chop, there are certain modifications in the vertical chop, which especially in case of a relatively harder grade of cataracts. This is known as crater and chop, the crater chop, wherein a small crater, a small bowl is made within the substance of the nucleus. This crater usually wouldn't be involving the central dense nucleus part of it. What this crater does is that it gives you access to that deeper, harder part of the nucleus. So once you have made this crater, the phaco probe goes to the bottom of this crater, helps you engage the more deeper, harder part of the nucleus, and then you can appropriately vertically chop it. So in a harder grade of cataracts, wherein accessing the more deeper, more denser part of the nucleus may be a challenge, it's a good trick to make a shallow crater, just not involving the center, so that it gives you access to the phaco probe to impale onto the deeper, denser part of the nucleus. Once you got a grip, you can just chop it normally the way you chop, as if you are chopping a softer or a moderate grade of cataracts. Another variant wherein more NS3, 4, more 4 and beyond denser grade of cataracts, you can have a crater involving the center of the nucleus. So you end up creating a crater central ball. So it does certain things. Once you have created this central ball, what it does is that it gives you that central space wherein it allows for all 360-degree subsequent chopping. That is one. You have sort of debulked the central hard dense nucleus. That is the second one. Once you have achieved this with a good 360-degree access, you can go ahead with whatever chop technique you are comfortable with. As you can see here, I'm going to do a horizontal chop again. So once this crater, it allows you to sort of reach that more deeper central harder part of the nucleus, which would otherwise be difficult to reach upon. And also once you have made these subsequent multiple pieces, If it was not done and a normal conventional vertical chop was done in such a case, what usually happens is with the difficulty, even with the suppression of the posterior plates, these multiple pieces what you have got, they are so cluttered because of the space constraint that is there. Sometimes it becomes difficult to get those pieces out of, although laterally separated enough, it gets difficult to get them out because there is not enough space centrally. So if you have made the central crater, these individual pieces at this point what you have made, it is easier to get them out of the bag. Even if you have a relatively smaller rexis as well, since you have made space for yourself, this space allows you to reach deeper portions, allows you to reach all 360-degree across, also gives you that freedom to get those individual pieces out, which may get crumpled if they are not made free in the center like this. So this is one variant of crater and chop, where a crater is made for a moderate grade, probably not involved in the center, and for a relatively harder grade of cataracts, you can make a crater central wall in this manner. I hope it was clear what I wanted to convey. I hope the techniques are
Yeah,
clear.
sure, sir. I'm not seeing any questions from the chat. You can proceed, sir. We'll stop you when there are
Sir,
questions, sir.
I have one doubt.
Yes,
Yeah.
please continue.
Sir, I think you have used some other dye to stain the angular capsule. Is it lissamine green?
No. This is post during the editing part of it, enhancement of the video part of it. It has become like that.
Okay.
Yes. It is during the post production part of it.
You can continue, sir.
Yeah. So the next technique is what is known as the burhole phaco chop, wherein using the phaco tip with long enough exposure, we make a burhole in the subincisional nucleus, as much periphery as possible. Once this is done, the nucleus is then rotated by another 180 degree. Now the similar nucleus engagement as we did for the previous chop techniques is done. Once enough purchase on the grip on the nucleus is got, using the first pit, that is burr that is made, using that as a crater and a long blunt Sinsky or a long blunt chopper as a second instrument, we do these maneuvers, getting these two choppers or getting two things instrument towards each other, towards the two burr holes thus made, we get a lateral separation. So the logic behind all the techniques seen prior is to get access to the more deeper and the harder part of the nucleus, which are hard to crack if not going for a direct vertical chop. Yes, we can do direct vertical chop in moderate grade of cataracts, provided you have reached that appropriate depth, you have reached that appropriate centerness of the nucleus. If not, these modifications in the vertical chop are definitely going to be of help.
Sir, regarding that burr roll technique, this thing phaco parameters, what you would recommend, sir?
Nothing. It's the same as what we use for trenching, because what you want is a hole to be made. So it's all about that. Any parameter which allows for your nucleus, your phaco tip to be getting impaled onto and engaging onto the nucleus and eating it up is good enough. There is no, I think a normal trench technique is good enough. Probably if you want to reach a more deeper depth, I would have my power increased by probably another 5-10 units. Apart from that, nothing else. It will be a routine phaco 1 setting wherein I'll be making a hole. So followed by once you're rotated by 180 degree, probably once you're cracking it, you can go to phaco 2, your chopping setting.
But because during the burr, it is recommended to have a slightly lesser vacuum, sir, so that you don't, because since you are creating a hole, even a 40 millimeter mercury also you try sometime impale the nucleus. So bring down the vacuum a little more,
Yes.
and then create the burr on both sides.
Possible. That's there.
Any questions from our participants here? You can proceed to the next video, sir.
Yeah. So now we have been seeing all about the vertical and horizontals. So let's look at a technique which is somewhat different. It's something known as the supranuclear techniques. The supranuclear techniques, what you're going to see here is for a relatively softer grade of cataract with a good hydrodissection. One pole of the nucleus is sort of popped out, and while the other pole is still sitting in the bag. At this point, the second instrument needs to be positioned in this manner. This is to prevent the gush of fluid from the phaco probe, once it gets in, it may push the nucleus back in the bag. You do not want that to happen. So prior to getting your phaco probe inside the eye, it's a good practice to have your second instrument positioned posteriorly in this manner, preventing nucleus from being pushed back into the bag. You go in with the phaco probe, you emulsify the part of the half of the nucleus which is above the capsular plane. So it is the supracapsular emulsification. Once that is done, the remaining heminucleus or the second half will just topple upon itself, which then can be easily emulsified. With the softer, being the nucleus being softer, it is easier to emulsify the second half as well. This is known as tilt and chop, or probably tumble and chop technique. The similar tumble or tilting technique can be done in case of a hypermature Morganian cataract. My technique in these cases would be, as we are aware, in a Morganian cataract, we have a small central nucleus with emulsified or with sort of liquefied cortex around. So once you are done the rhexis part, which is a bit of a challenge in this, what I tend to do is, once the rhexis is completed, once all the liquefied cortex is aspirated, I tend to get this small nucleus ball which tends to dance around. I tend to get it above the capsular plane. Once I have got it above the capsular plane, if you could see here.
Sir, Dr. Arun wants you to repeat the burr hole
Yeah.
technique again, and is
Yes.
asking what are the two instruments used for the burr hole chop.
Yes, we'll go to the technique. So this will be sub-incisional initial hole what we have made with the phaco probe. The second instrument is a sort of a Sinski, which is flattened out diagonally. So this is you can use a normal any plain long Sinski as well. It need not have to be the flattened end ones. What I am using here. You can use a long Sinski as well. Once you have rotated it by 180 degree, you can even use 1.25 or 1.5 mm Sinski to sort of use the initial burr hole made as a crater to impale the second instrument into the deeper planes. Once you have engaged with the phaco probe, you just take the instrument towards each other and then laterally separate. So the second instrument used here is sort of spatulated, diagonally spatulated one. You can use any long Sinski as well. That allows you to access the deeper plane of the crater what you have created.
And regarding supracapsular phaco, sir, one
Yeah.
thing juniors confuse is that supracapsular phaco is the same thing as doing phaco in the AC. Both
No.
are not. Yes,
Yeah,
it's
yeah.
different, because in the microscope, the surgeon knows that he is doing it at below the iris plane and just above the capsule. So it's
True.
not the same as doing phaco in the anterior chamber.
True.
That's one point. I think the Morganian one you can show once more, sir, because that
Yeah.
video got cut.
Yeah. So in the tilt and chop, this, as you can see, is for the softer grade of cataracts. When it comes to Morganian cataract, once you have done the rhexis, you have got the nucleus out, what I tend to do is engage the sort of So at this point, the second instrument, what I tend to do is, once the nucleus is lying in front of the capsular bag, second instrument goes across, engages the posterior surface of it, gently lifts it so that it tilts a bit. At this point, I would go in with my phaco probe, engage exactly the central part of the small central nucleus. At this point, the maximum surface of the phaco tip has to be impaled across the surface of the nucleus so that it doesn't run around because of the fluidics that is happening. So once you get a hold on to the substance, the literally nucleus is standing vertical here. At this point, the second instrument, usually the ball chopper, which is sitting across at the opposite end, you just crush them. You just mechanically crush them, and you tend to get a crack and a suppression. So these small nucleuses in case of a Morganian cataract are a real challenge, because it is very difficult to sort of, keep it vertical, keep the phaco probe engaged and literally doing the horizontal or vertical or whatever chop you are going to do. It is really impractical to do it in such a cases. But with this technique, you can just topple it, tilt it at one end, one pole will be held by the phaco probe. The ball chopper goes across. Once that is done, you just crush it. You just mechanically press against each other and you will have a lateral separation. Once these two pieces are done with, you can easily go ahead and emulsify, eat up each of the pieces.
No, you can continue, sir. I think we
Yes.
have half
So
an hour.
this subsequent so I would like to ask what the participants here, one problem what we face in case of a harder grade of cataract would be any challenges you guys face when it comes to NS3, NS4, these brown grade of cataracts. I'm talking particularly with respect to the phaco chop part of it. So any particular query which or issue which most of us face, if anyone could tell.
The better question would be to how many of you are doing phaco for brown cataracts, sir?
Yes, literally NS3 force.
Yes. I think many would be opt for a MSICS because
Yes.
that would be the safer part.
Yeah.
Is any audience are doing phaco? Yes.
For NS3, I do modified vertical chop,
Great.
and NS2 also I do the same thing.
Yes.
NS4 as of now I have not done.
Yeah.
chop.
So main challenge when it comes to harder grade of cataracts is separating that central posterior plate. You know, you have got the chops done, you have got the peripheral nucleuses, sort of separated. Problem is there will be a central posterior plate adhesions which are really hard to crack by. In such a situation, in such a grade of cataracts, this technique provided mentioned by Dr. Lana is really helpful, which I'll be discussing subsequently. I'll be showing it right now. So for this to happen, a good nucleus rotation in this manner is important. This is to ensure good cortex as well as the epinucleus, if at all there is any. This nuclear rotation ensures good cortical as well as epinucleus separation from the capsular bag. Once that is done, a good nucleus rotation and a free mobile nucleus in the capsular bag, you go in with the phaco probe, aspirate as much of the anterior cortex and the epinucleus as possible. Not only the anterior central epinucleus, I would want to clear as much of the epinucleus which is underneath the anterior capsule margin as well. As much as possible, I would want to sort of clear that off as well. Because what we are going to do is in this technique is necessitates as much bag contents to be evacuated as possible before doing it. So in this technique, what we do is similar to how we engage the opposite equator in case of a horizontal job. We have engaged the nucleus in this manner. With the second instrument, we are going to topple it. So what you are doing here is this. You can see, if you could see again, similarly to engaging the opposite equator, how we did, the second instrument, the ball chopper is engaged at the pole at this manner. The phaco probe then helps to topple the nucleus upon itself. What this does is, in case of a harder grade of cataracts, it exposes you to that, the posterior, the feared posterior plate, which is hard to crack. It just exposes it to you. So once that posterior plate is exposed, you go ahead with whatever technique you are comfortable with, because now that posterior plate, which tends to be, leathery, shiny, you have exposed it completely, and you have sort of made a crater in it. You have sort of debulked it, and subsequent finishing it of the cases becomes relatively easier, because the softer part of the nucleus is actually behind. The toughest part you have made more accessible to yourself. So it becomes easier in case of a harder grade of cataract if you happen to topple it. So one thing about this technique would be, as much as possible, debulk the bag contents as much as possible. Other thing would be, I would like to have a relatively larger rexis size in such a situation wherein I am planning to sort of, topple the nucleus, which facilitates me to do the same. So a larger rexis and evacuating as much bag contents as possible would be easier in such a technique.
And I think you can topple it just like a SICS case, sir, in case people are in, that doesn't have to be done with a phaco
Yeah, two
probe.
separate instruments, true.
Yes. Instruments, Sinski hook and Sinski hook in your left hand also, you can topple this technique.
Sure.
Because this makes that posterior plate the most hardest part to be eaten up first.
True.
The separation easy, but to be done with caution, provided zonular integrity, everything is fine. And I think you need to have a good hands regarding when you can topple the nucleus without disturbing the back complex. Nice video, sir. We can proceed to the next one if there are no doubts.
Yes. So since we are talking about chopping, let's look at the some pre-chop techniques. This is not my video. This is the my loop. What they are using here. This my loop has got a titanium a loop at the tip of it, and it has got a lever. The advancement and retraction of which results in the opening up or closing up of the loop. So once you are in, the lever is advanced, resulting in the opening up of the loop. Once the appropriate opening up of the loop is ensured and it is large enough to engage the entire equator of the lens, you sort of pronate your hand. As you can see, a silvery reflex passing across against the posterior aspect of the nucleus. This ensures complete engulfment of the loop across the nucleus. Once this is done, we one goes ahead with the retraction of the lever, which results in closing up of the loop. Which, as the loop closes in, it starts cutting across through the substance of the nucleus. At this point, a second instrument can be used to sort of give that counter, which allows for proper tearing apart of the nucleus while the loop is closing up. So even with a harder grade of cataracts like this, without much use of a vacuum or a phaco power, we have got nucleus pieces which are disassembled. Now you can go ahead and have subsequent pieces done using the same my loop as well. The two heminucleus which tends to dance across can be held in place by the second instruments. At this point, once you have engaged across the entire substance of the nucleus, visualization of that silvery reflex passing across will be difficult. In such a case, a technique would be to nudge the nucleus across so that you get an idea about the complete engulfment of the nucleus. So once you are nudged it left, right, above and below, you can go ahead and sort of advancement retraction of the lever, the loop closes in and it cuts across even the harder grade of cataracts in this manner, which with which you end up having the subsequent pieces you are having with use of no vacuum or no phaco power as well. This is a Akahoshi pre-chopper. It has got a sharp edge and a blunt end. You go in with the sharp edge, you press upon the substance of the nucleus, impale upon it. Once appropriate depth is reached, you just laterally separate it, getting a separation. No vacuum, obviously no vacuum, no phaco power is used. The same instrument then can be used to rotate the nucleus in this manner. The two heminucleus can then be further subdivided using the same chopper. The sharp edge of it is used to impale and laterally separate. The blunt end then can be used to ensure good lateral separation in this manner. The last technique, another sort of pre-chop technique by Dr. Lande. This is Dr. Dholakia's IOL cutter actually. This IOL cutter can also be used to deal with the harder grade of cataracts, which are difficult to chop, which are difficult to sort of get multiple pieces onto. So the same this particular IOL cutter can be fitted on to most of the commercially available phaco machines that are there. You just need, once the prime as for the routine phaco is done, you just need to change from phaco tip to this particular tip, and in a continuous phaco power mode, you can just, like in for the horizontal chop, engage the second instrument across the opposite equator, which allows for stabilization of the globe while you are cutting through with this pre-chopper. Like it just cuts through like a cake. I do have tried this technique. I do have this chopper. Since my recordings were not available, I'm just going ahead with Dr. Lande's video. So the engagement of the nucleus is done in this manner. This is very important. This second instrument, engaging the nucleus and holding it in place, is very important, so that you have a good purchase, you have a good grip on while you are cutting with the pre-chopper using this. So once multiple pieces are you have made using this, this is especially useful in case of a harder brown grade of cataracts which cuts like a butter. Once this is done, you can shift and move on to your normal phaco probe and eat the pieces of overall, reducing the overall probably phaco ultrasound energy that is used, because you got the pieces done without the use of much of a ultrasound energy. So this is
Sure,
all I
some-
could cover when it comes to nucleus disassembly. Probably femtosecond was would have been an add-on, but there is nothing much to show in there. So surgically challenging ones are this. So I hope I covered it all.
Excellent videos, sir. You have, I think, done most of the techniques available till date.
Yes.
Just for completion sake, is this the IOL cutter from Dr. Dolakia? Is it similar to the Ultra Chopper that the Alcon company use? I think it's a similar mechanism, but this was meant for IOL cutting, if I'm remember.
Yes. True. It is the same. The titanium material is the same. This particular cutter, what I have mentioned, what I am using is the same Dolakia IOL cutter. It cuts through the IOL like a butter, the same way it does even for a harder grade of cataracts. Only
Okay, sir.
thing is orientation of the second instrument, use of ball chopper going across and stabilizing is the thing you need to be well versed with.
Okay, sir. Dr. Srujan, you had any questions now?
No, sir. Nothing. Thank you so much, sir.
Yeah.
Thank you. Yeah, are there any other questions from our participants? I think Dr. Senthil sir has joined in the end.
Yeah, I was there on and off. Yeah.
Sir, comments from you.
No, I never knew that you were such a good surgeon. So today first time I understood that, okay, sir, you are on par with any superb surgeon. So the
Thank you.
whole idea of this program is to actually bring the unsung heroes to the forefront. So it's not that only the senior people should be doing these. So when I see your videos, I understand that you got such a good experience and quality. So
Thank you,
that's
sir.
less than any top people. So that's some one thing which we understood.
Sir,
And
most of these videos, my videos are there on my YouTube channel, sir, like with the proper text over and voice over describing all the techniques. So it's available on my YouTube channel by my name, Shailesh Dapke only.
yeah, but nothing better than hearing from you, no, or live.
True, sir. True, sir. True.
And so though the participants were less, I think still we have a quality crowd, and thanks to Dr. Mukul for
Yeah.
taking up this initiative. So even if 10 people are joining also, we can share knowledge. That is the
Definitely.
don't need a lot of people, and slowly the momentum will build up. Only thing is consistency. I think we should consistently be doing it. So that's
We are there, sir. Anytime. I am available. You just let us know.
I think Dr. Mukul, we can also add Shailesh into our faculty. So,
Sir,
Always in, sir. Always in.
so we will, I think next time what we can do is get one speaker from a medical college so that we can get some PGs also to attend. That's the
True.
thing we can. There are so many good surgeons working in medical colleges. Maybe they're not known beyond the postgraduates. Because even in my college, we used to have Dr. Venkatesh, who just passed away some few months back, one of the best surgeons. He was not very much known outside the medical college side. Basically, there's so many good surgeons, teachers in medical colleges. So we should also get them, or maybe get something LASIK or something next time should also be interesting for other people. So
let's work on it, sir.
so thanks for a very nice presentation. I think you kept engaging for the one. Only thing we had more people, it would have been more interactive, but still it's fine. I think a lot of people see on our YouTube channel also. So that's
Sure, sir.
And thanks to Dr. Mukul for all the initiative, and so he is also a part of Ophthall.
Thank you, Mukul. Thank you, Senthil sir, for having me.
Yeah.
Wishing for more engaging activities in future as well. I am always available. Do let me know.
Yeah, thanks to all the participants. Any comments from the participants like Dr. Srujan, Dr. Arun, a few people who have participated? If you can give your suggestions.
This is the first time I'm attending this webinar. I'm really, I'll gain a lot of knowledge.
So where are you located, doctor? Where are you practicing?
I'm right now in Northeast. My
Okay.
wife is doing post-graduation here, so I'm along with her.
Okay. Which place, sir, in Northeast? Meghalaya.
Naharlagun.
Oh, you are in Nagaland. Okay, okay. Good, good. So
Nice, sir.
nice, nice. So
Thank you so much, sir. Thank you so
yeah,
much.
yeah. So thank you all for being a part of this session, and looking forward to more participation next time. And please be a part of all the Ophthall initiatives. A
Yes,
lot of
yes.
things are going on. Today we had this orthoptics session, and then Sunday we have our PDP, where we have opticals happening, practice development program. And tomorrow, in fact, I'm going to Kolhapur. There is the Kolhapur Ophthalmic Society. We have a session there tomorrow.
Right, sir.
Good, and we are able to do because of support of people like Mukul. Otherwise, it's very difficult to do things. I always believe nothing can be done by a single person. So
True,
we
true.
can do so many
Still,
things.
still you are doing enough, sir.
It's because of support of people like you. Otherwise, how is it possible?
No, I should thank Dr. Sailesh sir for agreeing, sir. He's a busy practitioner and that to conferences and all, he presents the video so nicely.
No,
So,
he will
sir
do
was,
anything for Ophthal. So
yes,
he
sir.
cannot refuse for Ophthal.
Yes.
The Senthil sir knows how busy I am, so don't worry. Sir knows.
So, thank you, Dr. Sailesh sir, for agreeing and wonderful video collection. I am sure this will be available on YouTube or for later watch also. And I would like to just request any participants, if they're willing to share their video, please reach out to the Ophthal group.
Yeah,
We can.
actually, one thing which we can do is if the participants are okay, they can actually, it need not be very good surgery. If they have a doubt, they can
Yeah.
record their videos,
Record
play it
suggestions.
for the support, comment, and suggestions from other people. That's the main thing. But I think people are a little hesitant to show their.
It can be anonymous also, sir. That's it doesn't have to be. It can submit
Yeah,
the
or you
video.
send your videos without mentioning your name only. We can play and discuss
We
on
can
it.
play it and comment on it. We'll get an expert to comment just to know where the steps or what mistakes are going on, just to
Yeah,
improve your surgeries. Even that can be done. Because
correct.
I get the requests, sir, that they want to do it, but no one has come forward.
So let's have a platform that way, no? Wherein only the what they do in FECO development program for Alcon, what they do is surgical recordings on a daily basis are assessed. Let's make a platform for PGs to put in their videos wherein we can call in experts
That's the
and
reason for the Telegram group which we have kept, sir. Because you
right.
can just post the videos there, and if
Yeah.
any auditing or anything is not, we can just mention it there, and we can present it in the upcoming surgical club meet, and just have a comment by our presenter and our speaker also, so
They
that
don't want to tell their names also. They can just send it to Dr. Mukul. So without disclosing the name of the surgeon, we
Yeah.
can
Yes.
discuss the video. That is also what fine. So otherwise, how is it possible to learn? It's very difficult to
No,
when
that
you're
stigma is still there, sir. That sharing video, that some as if I don't know, it's going to degrade their practice or something. Nothing's going to happen. You'll just learn and be a better surgeon at the end of the day. So
yeah.
that part we have to promote, sir.
And when doctors are willing to help, you should always take that support from the seniors. So we'll plan. Let's plan something. So next session we'll have 100 participants. That's the target. So let's
Sir.
do
Yes,
it
sir.
next time. Okay. Thank you all and
Thank you,
have a
sir.
nice weekend.
Thank you,
See
sir. Have a good evening.
Good. Bye, bye, bye. Good
Thank
Thank
night.
you, all participants. See you in the next club meet.
Yes. See you.